Hello, my name is Incy Muir, and I'm the Executive Director of the Farmington Valley Visiting Nurse Association. Joining me is Karen Bignelli, one of our nursing managers who supervises our homemaker home health aide department and who also serves as our quality assurance nurse. The Farmington Valley Visiting Nurse Association has been in existence for over 100 years, and our roots originated right here in Simsbury. Certainly we know healthcare has changed and evolved tremendously over the years. We're hearing a lot today about healthcare reform, but we're still uncertain of how reform will actually affect healthcare in the future. However, we do know that home healthcare and in-home hospice services are an integral part of the healthcare system. Home care is cost efficient, saves the government money, and people want to remain in their own homes when receiving care to the degree possible. Our program today will address some of the most common questions our agency receives from the community pertaining to home health and hospice. Certainly, Karen, in your role, I know both of us and many of our staff receive many questions from the community. People are confused about home health, what it means, and what services they can receive.
Exactly.
And I think the first question we get, and I think the most frequent question we get, is who can refer a person to the VNA or to home health care? And I know that when we respond to that, there are a number of answers to that. We know primarily home health referrals come to us from the hospitals when people are in the hospital.
Skilled nursing facilities.
Right, from physicians. Often the physicians' offices or their staff refer patients to us, but that's not the only place. We also receive referrals from nursing homes, from assisted living facilities, from social services departments, and people also refer themselves or their family members to us. So the answer to that, and something that we tell people, is anyone can refer to the VNA or can ask for home health services, and we will accommodate that request and do the best we can to provide those services after getting information from those sources.
Right. And what I get for questions a lot from the community is, well, how do I select the home care agency once I know I need a home health care agency? How do I go about selecting that? And I think the first thing we need to make sure they understand is they do have a choice, and their discharge planner should be presenting them with a list of home health agencies when they're getting ready for discharge. And it's also important that they know that if they ask for the VNA, may not be the VNA they're thinking of, that the VNA is just a generic term.
That's right.
It's not, we're not one big happy VNA family. It's a general generic term for home healthcare agencies. I think it's important that they look for a licensed agency. I think that's really important. And the Farmington Valley VNA, we are a licensed agency, which means that we are subject to state regulations and state audits, and they do come in regularly. And check on us and make sure we're following state recommendations and state protocols and regulations. And licensing means that we're checking backgrounds, criminal checks, drug checks, so that when these people come into their home, I mean, you're letting these people in your home. You want to know that this person is a reputable person and not only able to give you good care, but has passed a criminal and drug background test.
Right. I think just to add to that, what I hear very frequently from people who even know about our agency is that they thought that all visiting nurse associations were part of one big entity, or that they're all the same, or that we're all affiliated in some way. And that's actually not true. Even though we use visiting nurse association as a generic term, there's no branding for that. There is no trademark for that. We call ourselves visiting nurse associations or VNAs because most visiting nurse associations evolved from history, going back hundreds of years, and that was the only home health provider that was available. Today there's so many home health providers, and the term VNA is now so generic, as you've said. We almost call it the Kleenex brand because it could be any brand, but VNA and visiting nurses is so generic. So we really do try and tell the community and educate them that they should be informed consumers. Whoever they choose for provider is absolutely up to them, their choice and their privilege, but they should understand the difference, that there are different organizations. Our organization, the Farmington Valley VNA, is an independent entity. We are nonprofit, but we are the local community VNA. Okay.
And we're very community oriented,
Right.
very invested in the community.
Right.
And we do a lot of things good. You want to pick a home health agency by their specialties. We're very good at wound care.
Mm-hmm.
We have a very high rate of success
Right.
in healing wounds in as quick a time as possible. We have access to all the latest technology for wound care. And our rehospitalization rate is very low for the state of
Right.
Connecticut.
We're proud of that.
So you want to look for those things. How is your home care agency going to treat my individual illness or my individual wound or my problem? And what do they have for services? So you got to go on the net. You got to search the web, and maybe you have a family member that can do that for you, or do it yourself if you have internet access. But visit the websites and check them out. Make phone calls, word
Right.
of mouth. Ask your neighbors, your friends.
Right.
Did you have the Farmington Valley VNA? And did you have a good experience? Yeah, they were great. Okay, I'm going to call the Farmington Valley VNA. Yeah,
Right.
we do a good job.
Well, I think that the whole point of the credentialing, too, is important because it is, I think, critical that people understand that if they choose an organization that doesn't necessarily do some of those things that other organizations and ours
Exactly.
do,
What do
such
they
as the
have for
criminal background
yeah.
checks, the checking of the references, certainly providing the training and education, doing the drug screening as standard before people are placed in the home. That is really important. I think we've all seen articles in the paper where elderly people have been taken advantage of or robbed. I mean, certainly those are the worst case scenarios, but with some advanced type of screening and due diligence, as
Yeah,
we
we can
consider
avoid
it,
that.
hopefully we keep that to a minimum or avoid it altogether. So
And
it
you
is
wanna-
important that the consumer be educated.
Exactly. And you want to know what kind of services you're going to get from your home care agency. Do they have full services, physical therapy, occupational therapy, speech therapy? We have all those, dietitian, social work, so that if you go to an agency that doesn't have all of those services and then suddenly you need that service, well, now they've got to contract out.
Right.
So you want to seek out an agency like us that has full services and full staff. That just makes sense.
Absolutely. I think, too, the next big question is how is home health paid for?
Yes.
And what does Medicare pay for? And how is hospice paid for?
That's a huge,
it is. And
huge question.
obviously reimbursement is on everyone's mind. And the insurance world is getting more and more complex. Even those of us who have been in healthcare for years and years are confused with the variety of health plans and the different rules that seem to change almost every day. But certainly for our organization, and I think for most home health agencies who are certified and licensed, Medicare is their primary payer source. Medicare pays for home health care services. It's actually a wonderful benefit. And it pays for 100% of home health services under certain conditions.
First question I always get from patients is how much am I going to be responsible
Right,
for? And,
right.
and home care Medicare does pick up 100% of the services.
Right, and it is complicated though, because even though Medicare is an excellent benefit for home health and also for hospice, there are criteria that must be met by the patients, as we see in our agency, and those criteria are often gray in some areas. Even though they're written, they can be interpreted a little bit differently.
Yes.
But certainly we know as absolute criteria for Medicare coverage for home health, people have to be homebound, which means they really cannot leave the home without taxing effort, without the assistance of either an individual or a piece of
Concerted
equipment.
physical effort, yeah.
They cannot be going to social events other than maybe some limited external events, such as a religious service or a doctor's appointment or maybe a special wedding, that type of thing. Because basically Medicare's perspective is if someone can leave the home without great difficulty, they
Yes,
can
then-
seek their care elsewhere. They
Yes.
don't need home health.
Why should they cover it in the home if they can get it in the community?
Right. So that's definitely a very, very important criteria, and Medicare requires us to document that carefully and to evaluate that almost on a daily basis. So the government does look at that. We also have to have a physician's order for services because we are a visiting nurse association and provide services under a physician's order. We have to have a current physician in state or in an adjoining state, and they must be willing to write
Sign
orders for
orders,
our services. And certainly people need to be in a situation where they need a certain amount of acute or immediate care.
I need a skill.
That's right, as Medicare says.
Yeah.
And the care really has to be intermittent or part-time. That is right from the Medicare manual. They really don't pay for 24-hour care for some of the long-term chronic types of conditions, even though we would wish they would.
Yeah.
That's not the way the Medicare home health
I think
benefit is
sometimes
designed.
people don't understand that it wasn't designed to be a long-term chronic plan. It was always designed to be short-term and intermittent.
Right.
And once you reach that chronic stage, I mean, that's the way it was designed, and that
Right.
it works well in that capacity.
Right. There are, again, some exceptions to those rules. For example,
Yeah.
diabetics who don't have anyone in the home and they are not able to inject themselves their
Yes.
insulin.
And renal
they're-
patients often
Right.
are long-term.
Right. There are some exceptions to that, but generally those are the criteria that we have to abide by in order to provide home health services under Medicare, but it is still a very good benefit. And the other interesting point, I think anyway, from the Medicare end is that we as an organization, and again this is true across the board nationally, that Medicare pays home health agencies for 60 days of care. It's called prospective payment. It is a 60-day episode of care, and based upon the patient's condition, their need for services, their functional abilities, and based upon a mandated assessment tool that I know our staff feel is often very burdensome. It's very lengthy, but it's standardized, and it actually determines
And it's
how
very
much
comprehensive.
we receive
Yeah.
as an agency for that 60 days of care. It is in regulation, it is preset, and we are told what we will be paid. And then out of that 60-day episodic rate, as they call it, we then provide whatever services are needed for the patient. And that can include supplies, certainly all the services, nursing, physical therapy, occupational therapy, speech, medical social worker services, home health aid, all of those services. And we as agencies all have to provide what the patient needs within that reimbursement level. So that is a challenge, and people receive their explanation of benefits and often are confused by that because they don't realize that the payment that is made to our organization is really for 60 days of care based upon what the physician orders and what the patient's needs are. So that is very different. That changed in 2000, and even though that's a little bit invisible to our patients and their families, it's very much a reality, and the questions that come up really stem from people seeing their explanation of benefits and not really understanding how
that's broken
we're being
out,
paid and what is expected of the organization. Obviously, Medicaid, Title 19, and private insurances pay for our services. There are a number of special funds in the community that we use to provide care. We have the Brainerd Fund from the Hartford Foundation for Public Giving. We have a number of different special funds that we can tap for people who have needs, who maybe fall outside of the parameters of the traditional insurance systems. But overall, there are many. I think the federal government is the most complicated, but overall coverage for home health is quite comprehensive. We also know there are many long-term care policies that provide coverage for some home care services, but we encourage people to really read their policy and understand what's covered, because people are often surprised that what they thought was covered for long-term care pertaining to in-home care really isn't. So we often have to help people understand and actually interpret their policies. Some are very good plans and others are quite sparse. We also know that in the insurance world, authorizations, particularly with private insurance, is very complicated as well, because many private insurances require us to request prior authorization for certain services. They only authorize a very limited amount of care from the onset, then expect a status check and then a reauthorization of services. It's often trying to justify care that we really feel is needed by the patient, but we have to convince the insurer that it's reasonable and necessary. We often have
actually don't have too much difficulty doing that.
to advocate. Yes, but we definitely, that is
But it's a challenge at times.
And it's frustrating, I think, to our patients and our families, because sometimes those authorizations take a while. Again, we have some insurers that say they can't give us an answer for 10 days. Well, people need care, and we need to deliver it and want to deliver it very, very soon after people come home or the request is made. And we often will deliver those services even outside knowing that we're going to be reimbursed on good faith, and also knowing that if we really run into a problem, we will still deliver the care, and we will try and tap some funds if there are some issues, because as we know, our philosophy is to care for anyone. We don't turn anyone away, and it's regardless of ability to pay. But we certainly try and advocate for our patients and the families to get coverage where it's needed. But the whole insurance realm has just become much more complex, and I don't think it's getting any easier. And all we ask, and again, I know you're involved in this, is that people understand that this is complicated, that we're doing our best, and that we will help advocate for the patient and the family to the extent possible to get the coverage that's needed.
Get the appropriate care.
But it is very, very difficult. Hospice, on the other hand, which is, we have an in-home hospice program or a certified hospice agency. Medicare has a separate hospice Medicare benefit, which is, again, it's Medicare, but it is a component of the Medicare benefit that is specific to hospice. People have to elect hospice Medicare when they are in a position where they may need hospice services. They have to actually sign an election form. They are not forfeiting any benefits, but they're just basically saying, yes, I elect to use the hospice Medicare benefit that I have as part of my Medicare coverage, and the organization, the VNA, can bill Medicare for those hospice services. Once a patient and family elect the hospice Medicare benefit, we then provide in-home services and provide an interdisciplinary range of services for people who are struggling with terminal illness. Usually that means a prognosis of 6 months or less, but that's also not really written in stone, because we obviously can't predict that always. And then the hospice Medicare benefit will pay for levels of care. They will pay for days in the home. They will reimburse for any days of care that are necessary in an inpatient facility.
The respite piece of it.
Also for respite, if the family needs time away, a little bit of a break per se. The hospice Medicare benefit will pay for up to 5 days of respite care for the patient, and they will also pay for continuous care in the home. And again, very specific criteria with regard to what qualifies people for that. People have to be quite ill to be eligible for continuous care, and even for inpatient care, which is often delivered in a hospital or a nursing home for pain and symptom control, or if really the situation has gotten to the point where the family just cannot cope well in the home. But we know those levels very well. We bill Medicare accordingly. But again, it's 100% covered, which is wonderful. And the hospice Medicare benefit, different from straight traditional Medicare, will pay for medications that are pertinent to the terminal illness, and also any other supplies or equipment that are needed pertaining to the terminal illness. And again, it has to be specific to the diagnosis, but Medicare actually requires us to provide those medications or those pieces of equipment or supplies, and reimburse for those out of the money that we get paid for every day that we provide care. So it is, again, a very complex and unique system, but I think the message that we're trying to send back to the community is that there's very good coverage under the Medicare program, both for in-home home care and in-home hospice care, which we can do well. And then always, if all else fails, we have a sliding scale for people. Because we are a United Way funded agency, because we receive donations from the community, because we are proactive with looking at funding sources. We provide care on a sliding scale basis to people who have a hardship or have an insurance limitation, so that care can be delivered without concern for that patient or family feeling that they are going to go either without care or be billed money that for services that is just
ill afford.
Right, right. But I think, I mean, that's
You've
almost in a nutshell. I mean,
yeah.
we could probably talk all day about reimbursement, but those are the key points. I know those are the questions I get from the community about reimbursement.
From my standpoint, where I also do patient care, among the other things I do at the agency, but a lot of people ask me, how do you decide what services I'm going to get and how frequently I'm going to get them? And I just tell them usually it's individually based, and that's important to know, that it's not cookie cutter at the Farmington Valley VNA. We will go in, it'll be a nurse or possibly a therapist, could open the case, ask lots of questions,
Right.
look at the bathroom facilities, watch them walk. Are you steady on your feet? Do you need a cane, a walker? Have you had a stroke? Do you need occupational therapy for some retraining, or speech therapy for some speech training? Or perhaps a dietitian if they're a newly diagnosed diabetic, or some illness that has dietary restrictions. We have our dietitian, Mary Margaret, on board, and she's happy to go out and see those patients. So also social worker. I don't want to forget our social worker, Jim Fox, and he can do the long-term planning or any kind, even counseling, if someone is dealing with a difficult diagnosis and needs someone to talk to. We have all those services available. And basically based on what the needs are, and that would include even, can you dress yourself and bathe yourself? And do you need help doing that? Do you need help with your medications? Do you understand your medications? So do you need a nurse or a therapist? You know, sometimes you just need a therapist. Sometimes you just need a nurse. And the home health aide, of course, which would be paid for under the Medicare benefit, you know, to help you with your shower, bathing, maybe do a sandwich before they walk out the door, give you something to eat. And then, so I guess what I'm trying to say is it's individually based, and it's assessed on your needs. And we don't take the dollar amount into account when we're figuring out what the plan of care is for the patient. Because I think that's what a lot of patients get concerned about. Well, am I not going to get what I should get because you're trying to maximize your reimbursement? And I mean, I know we've always told the nurses at the Farmington Valley VNA that you do what the patient needs. And
that's certainly our mission, and
that's our mission.
That's what we do. But I think, too, that with regard to what services are provided, obviously we still have to work under the physician's order.
Yes.
I mean, the patient's needs are first and foremost, but the physicians are on board with us. We have very good relationships with our physicians, and it often is a conversation that either the nurses or our rehabilitation therapists have with the physicians to say, this is what we're seeing in the home. Physicians are wonderful. They certainly care about their patients, but they don't often see what's happening in the home, and we can interpret that.
Yeah, it's a whole different ballgame, and very often I'll have a physician say to me, well, what do you think? What are you seeing in the home? In fact, we've had physicians call us and say, I'm having difficulty with this patient. Can you go out and look at the home situation and tell me what's actually going, sort of boots on the ground kind of thing, what's actually going on in the home? So they trust us. And
also people, we also encourage our patients and families to also be advocates for themselves with their physicians. And we often say, well, if you have a concern, call your doctor. Have a conversation with your doctor. Tell them what you need. And often those physicians will then see and understand, and then we will get the referral for home health services. So it's all part of what people need and how often we can provide it.
And getting back to the insurance question, a lot of patients will ask me, well, when my insurance is done, what happens? I like having the home health aide come in a couple of days a week to help me with my shower. And, you know, what can I do afterwards? I mean, they're better, their pneumonia's resolved, or their whatever their episode of illness was, but they feel safe having the aide come in. And, of course, we can help them out there, too, because we have the private duty aide programs. So we can give them a home health aide for as many days or hours as they feel necessary, and homemaker if they're having a difficult time keeping up with the house chores, and the companion if they just need someone to be with them.
Right, and those programs really are growing. We're finding in the community that just some basic level of support in the home often makes the difference of people being able to stay safe and comfortable in their own home, which is where people want to be. And our homemaker and companion programs have grown tremendously in the past year or two. And it's really just a basic, non-medically necessary service that helps people so much in their own homes. It makes the world of difference.
Yeah, I think people are realizing that with that little added help, it'll keep them home.
Right, and it's our goal really to continue to grow that, because that certainly seems to be something that we're hearing people want more of and need. So we will be looking at that and continuing to expand that program. I think, you know, to kind of cap that, our goal is always to get people healthy, get back on their feet, and to discharge them. I mean, we want people to regain